Okay, today we're going to start the peritoneal and hemodialysis section. The title is Equally Important Dialysis Modality. I'm going to have the honor of introducing Dr. Wong Wing Kin, who is a colleague of mine and a friend. He's currently working in Mount Elizabeth Hospital. He is an interventional nephrologist, among other things. Without further ado, I'll let him start his talk.
Hi, good afternoon, everyone. And thanks, Chris, for a kind introduction. So, our task to compare between PD and HD. Our task to compare between PD and HD, which is something that I don't like to, because it's supposed to be complement each other. Sorry. Okay, this is my conflict of interest. Okay. Now, I think it's very important that when we discuss on a kidney replacement therapy, we need to start it right. I think, first of all, as a nephrology, we always need to push for kidney transplant. There's only gold standard kidney replacement therapy who give us the best outcome and also quality of life. Now, there is always an issue of a demand and a supply mismatch. So then the next thing, we actually should talk about PD. And there's a reason for it. I'll explain why we should talk about PD first and not HD, we should PD. And of course, while doing PD, and there's a time that we have in the wait list, get a kidney transplant, then you go for kidney transplant. Then after that, then we should talk about hemodialysis. And lastly, for certain patients with a lot of comorbidities, elderly, poor function status, then we should consider palliative care or conservative care. Now, nothing is stand in stone. So, of course, there's over time of treatment for everyone, then you actually can change between the modality. Now, despite a PD is a good modality, right? There's unfortunately underutilization of a PD in the most part of the world, other than a few area or country, due to the government policy. Even in Singapore, there's not even 20% of the PD per patient. Now, there are many potential causes of underutilization of PD. For example, can be a system-related due to lack of infrastructure, example, PD center or transitional care center. Now, when important PD is actually home therapy, we do need to handhold the patient and also the family members go through this therapy. Perhaps the lack of a private expertise, for example, PD physician, interventionist to put in a PD catheter insertion, and then you become a vicious cycle because you have no PD load, nothing to learn, then you will not promote PD. So there are also lack of physician reimbursement in many parts of the country, including Singapore. Ownership of dialysis facility, what I mean here is an in-center hemodialysis facility by the doctors. And I think in Singapore, one of the issues is that there are mushrooming of the in-center hemodialysis center. Now, if you walk out for any MRT station, you easily find a few dialysis center nearby, every MRT station in Singapore. Now, there could be a patient issue because of patient burnout, there are lack of family or social support, or perhaps a misperception of a PD. Now, it could be due to physician issue like us because of selection bias, because it's quite common we choose the fittest or the best for kidney transplant, and then those in between for HD, or we choose those with a big bowel, multiple comorbidity, right? Then we choose for PD. Then we make the worst outcome, and the renal registry also show a bad mortality, then nobody wants to choose PD. So it could be due to a misconception about the feasibility and the risk of PD, and lack of PD exposure, and experience for the physician, and lack of interest in PD catheter insertion again. Now, in fact, is that really so many contraindication PD? It's actually not true. The absolute contraindication to PD is actually very rare. Now, it includes documented loss of peritoneal function, extensive abdominal adhesion, or physically or mentally incapable of performing PD, in the absence of a suitable assistant, or uncorrectable hernias or body wall defect. And most of the other contraindications are actually relative or just challenges, including inflammatory or ischemic bowel disease, or frequent episode of diverticulitis, or abdominal wall or skin infection, liver cirrhosis with ascites, or stomies, or now malnutrition, or gastric duct, pulmonary disease, and obesity. Now, because of the underutilization of PD in Singapore, so it was just published just 3 weeks ago in our newspaper, where our government Ministry of Health would really want to push for more PD. It's more on because of the cost issue. So we want to push for PD and to achieve 30% of PD in 2035. Now, the reason I mentioned why, if you know transplant should do a PD first, there's a reason. Because when you do PD first, there are actually a survival advantage. In fact, we've seen early in the course of the kidney replacement therapy, and for the first 2 years. And of course, after that, the survival will be same between PD and HD, and this is influenced by comorbidity and age. Now, one of the importance of a PD is that you actually preserve the residual kidney function better in PD than HD, and it is not about just passing urine, right? It's about when we look at the residual kidney function, we are talking about other function of kidney, including the influence of nutrition, the cardiovascular function, the mineral metabolism, and also the anemia control. So loss of residual kidney function, increase in mortality, and perhaps the residual kidney function has been clearly associated with survival of PD patient. Now, infection is the second most common cause of death among dialysis patients, and the risk of hospital admission for sepsis or septic shock or septicemia are much higher than HD than in PD patient, and the risk of death from septicemia are almost 2 times higher than HD patient compared to PD patient. In fact, PD patient, the infection that people fear of is actually a peritonitis, and most of the time we can treat it as outpatient. I think the other thing is a home therapy and lower healthcare costs. PD is the most efficient home therapy dialysis comparison to a home HD and in-center HD. And PD patient most likely than HD patient to be less likely to be hospitalized in the first 2 years, have a lower healthcare cost. And then the real reality is that during this pandemic, there's a growing healthcare expenditure and COVID-19, and home therapy do reduce the risk of cross-infection during our pandemic. Urgent start PD is actually important to reduce the HD catheter use and hospital stay in the crash landing situation. And later, the next speaker, I think Joy will speak to you on his experience on the Urgent Start PD program. And this will be my last slide to compare. You really want to compare between HD and PD, the benefit and risk. So the PD, the advantage of survival benefit first 2 years, the maintenance of residual kidney function, the less delayed graft function post-transplant in some of the study, the patient autonomy, patient satisfaction, lower cost, and important lower CVC use. Of course, there are risks of technical failure, like membrane failure, infection, their weight gain, their poor glycemic control in a diabetic patient, or patient and caregiver burnout. Now, then we are comparing to in-center HD, so the benefit could be less patient responsive, of course the nurses doing the task, and they can communicate to each other, their friend in rather than isolation in the HD center. The risk is the infection, like bacteremia, sepsis, vascular access complication, and intradialytic complication like hypertension, cramp, myocardial stenting, and post-dialysis symptom where they feel washed out from the dialysis, and also increase mortality, especially after the the long weight gain because of the 1 week, 1 day extra among the HD patient. And with here, I thanks for your attention. I welcome any question.
Thanks, Wen Kim, for the wonderful, comprehensive talk. Shall I invite anyone for any questions?
Thank you for that excellent talk. I do AVFs and I do transplants. And one of the things that I noticed on your second slide, you talked about we want to get most patients a transplant. Yeah. And one of the things that really disappoints me is when I have a patient who's been dialyzing happily for 5-6 years, and then we do a transplant, and after 2 years, they're dead because of sepsis or cancer. You know, they just have these complications as soon as we start the immunosuppression. But then on the flip side, my nephrology colleagues are so keen on transplantation, but I don't know if that is the right thing for all patients. Do you have any comments?
Now, that's a very good question, because we do have a patient in our center who dialyzed for 10 years, 20, 30 years, and actually they reject transplant. And they tell me the story that, no, doctor, you see the next one to me, he just passed away immediately after the transplant. See? So you're right. I think they do have a complication, including the side effect from the immunosuppression. But most of the studies have shown that in terms of quality of life and the best outcome, right? And also, it's not about the dialysis and survival. Also, in terms of the functional status, anemia control, metabolism.
Good afternoon.
So the best are still with actually transplant. Of course, there are cases that people did not do well on transplant, but majority are actually doing best, among all the HD modalities.
Okay, thank you very much, Dr. Wong, for the wonderful talk. Next, I would like to introduce John. I don't need to introduce him anymore, except to tell you, other than going to war-torn areas, he climbs mountains as well. We climbed Kilimanjaro quite a number of years ago, so he also conquered mountains in Africa. And if you're interested, I actually have a video of him on 60 Minutes in Australia. He did a feature there. It was really nice. John, go ahead.
Okay. Thanks very much for being invited to this great meeting. I think it's not just good for Singapore, but it's Singapore, sort of the centre of Southeast Asia, Australasia, and that's what this meeting is for dialysis for that area. So I was known as a PD, as a HD surgeon, a fistula surgeon, as an ultrasonographer, until about 5 years ago when I became also a big-time PD surgeon. And really have not converted to PD, but vigorously embraced it. So, as you know, there's the 4 modalities for renal replacement, and PD is grossly underused worldwide. There's 4 ways of establishing PD: open surgery, laparoscopic surgery, which is the default method throughout the world. Most PD catheters are placed laparoscopically. Peritoneoscopic techniques are becoming obsolete, and Selding a PD, which has been around for a long time, but is very variable in how it's done and how well it's done. And it's Dr. Behram here at this hospital who first introduced me to this idea about 8 years ago. And I thought, oh, that's not a bad idea. So the reason I went into PD was because I've been trying to lower the rate of VASCATH use on first dialysis at our hospital for decades. And I was unable to change it. It was stuck around 57% in Australia. So half our patients start dialysis with a line in their neck. And I thought, if we use Selding a PD and urgent start PD, maybe we can change that. So this is the team I put together. Luke Baker, an interventional radiologist who has a lot of experience with peritoneal access. Katrina Chow, a nephrologist in Blacktown, and myself, and those other collaborators. And why urgent start Selding a PD? This was elaborated on by my previous speaker. No need for VASCATs and VASCAT complications. No need to wait for fistula maturation. And no need to wait for PD healing. It's readily done without general anesthetic, and it can be done in the sickest patients. And that's one of the emphasis of our talk. We do this in patients who are at death's door from ICU, a lot of them. And we can do it in obese patients and fully anticoagulated patients. A number of our patients we've done with a heparin infusion running because these people had an infarct 6 hours ago and went into renal failure. That's why I started the program. But the reason I've really pushed ahead is because there is these other enormous advantages. It preserves residual renal function for 2 years. And you'll say, what's 2 years between friends? But remember, a lot of our patients are elderly diabetic with a life expectancy of 2 to 4 years. This is half their life expectancy we're talking about. Secondly, it prevents institutionalization of patients. And this is a huge problem I was unaware of. The renal physicians see all these patients going into renal failure. They organize PD. Yes, we'll do PD. All's good. But then they have a heart attack. They crash into renal failure. They get their VASCAP. End of story. No PD. And any renal physician dealing with this sort of problem will tell you that's the truth. Our HD units are overloaded and PD is much cheaper. And the way I'm selling this is PD is an essential tool for the endovascular fistula surgeon. This is not an abdominal operation. This has got nothing to do with general laparoscopic surgeons. It's a vascular surgical procedure. It's an interventional radiology procedure. It's a get-out-of-jail-free card. If you've got a steal from a fistula, they ask me, do you do drill procedures and all that? No. You ligate the fistula and you put in a Seldinger PD and start them on PD. If you've got impaired cardiac function that's not supporting the fistula, tie off the fistula and put in a PD catheter. So what do you need to do Seldinger PD? It's an endovascular technique using all the usual things. You need high-grade ultrasound, radiological imaging, a range of endovascular equipment. You don't need an anaesthetist, but if you do this in the really sick patients, it's nice to have the anaesthetist there, not for anesthesia, but to keep the patient alive while you do the procedure. Some of them are very sick. So these are the steps. Reverse mapping, that's from John Crabtree, an American PD surgeon, very important. And use an ultrasound to make sure the bladder's empty, to identify your peritoneal entry site and to avoid the 2 arteries. So that's your pubic symphysis, that's your marker zone for where you put the catheter, the umbilicus, belt line, exit zone. So this is the reverse mapping. You put the pigtail in the pouch of Douglas. That's where your internal cuff goes. That's where you enter the peritoneal cavity. That's your incision, 5 millimeters. So the whole operation is done through a 5 millimeter incision, external cuff, and exit site. This is our first patient. I asked for a nice, slim, healthy young patient to start with. So they sent me this nice lady. And there you can see the catheter, the belt line, internal cuff, incision, external cuff, exit site. Accessing the peritoneal cavity is the critical step. Once you've done that, it's all paint by numbers. And you got to get 3 directions right. You've got to get the right anteroposterior direction so the catheter ends up in the pouch of Douglas, not in the iliac fossa. You've got to get the right angle through the belly so you end up with a nice flap valve through the belly that stops leak. And you've got to have a low peritoneal entry. The trouble with a high peritoneal entry there is that you end up with a long arm in the belly, and that catheter can go anywhere, under the liver, into the omentum. Whereas if you do a very low peritoneal entry, you've got a very short catheter length in the belly, and that catheter can't get out of the pelvis, so we don't suffer from catheter migration. So this is our puncture. Here you can see beautifully our needle tip going into the peritoneal cavity there. Then you do your first peritoneogram. This is a 22-gauge spinal needle, so you can't do any harm with that. There's your peritoneogram. I'll just show you this quick video before I run out of time. So here's your 22-gauge spinal needle. You inject the contrast, and there is absolutely no doubt that you're in the peritoneal cavity. You can see that spider web pattern. Then you put in a microsheath, so you're still quite safe with that. It's only 4 French. And you do another peritoneogram through your microsheath, showing that you're in the right place. Then you put in your Benson wire. Then you dilate. Then you put in your sheath. Then you do a sheathogram to make sure everything's right. Then you put in your catheter. There's your catheter deploying into the pouch of Douglas. Whoops, sorry. Just a quick video. Can you play the video, please? Can you play the video, please? Yeah. So we don't bury the cuff or make a big incision. We just grab the cuff with a pair of forceps, push it into the fat. That's all. And then you exit site through the blunt trocar. and then you do a final run to make sure that your pigtail's draining freely, it's in the right place, and there's no kink in your catheter. So this is the algorithm for our project. This is how it used to be. Patient crashes into renal failure, admission to hospital, vas cath placed, in-center dialysis, discharged after their acute illness settles. They go and see the laparoscopic surgeon. They have an anesthetic review. They come back into hospital, have a GA and a laparoscopic PD. Then they have initiation of PD, and then they go to the outpatient for vas cath removal, and that can all take 10 weeks. What we do now is the patient crashes into renal failure. We put in a Seldinger PD. They start PD in the ward, full volumes, straight away, same day, and then they get discharged to home PD as soon as their acute illness is settled, and the whole thing's over. So in the interest of time, I'll just skip over our results. So we've done 130 cases in 2 years. So we've taken over the entire PD service, essentially, but we still use the laparoscopic surgeons for a few select cases. This is urgent start PD. 17% we use the catheter within an hour of putting it in, and about a third we use the catheter within 3 days. No deaths, no organ perforations. So just my conclusions. What's new? It's a very safe technique. It can be done under local anesthetic as an outpatient, and it can be done as an inpatient in the sickest patients who crashed into renal failure. It can be done in the morbidly obese and in fully anticoagulated patients. Doesn't require an anesthetist or an OT facility. It places the catheter in absolutely the right position. It keeps the catheter there, and the whole procedure is done through a single 5mm incision. It allows for immediate full volume PD without leak. It avoids the use of vas caths into patients crashing into renal failure. No hemodialysis damage to residual renal function. No institutionalization of patients. It's much cheaper. And finally, it places the PD skills in the same skills sets as HD. It allows PD and HD access delivery by the same specialist. It helps prevent inappropriate allocation of PD of patients to the wrong treatment because the person doing it can do either. It minimizes cross-specialty referral and offers an endovascular solution to intractable problems. This is my wife, Dr. Ruth Carter. She's my life partner, a retired GP, a mother to my 4 children, an aging hippie, as you can see by her guitar, a keen gardener, and my lifelong lodestar. Thank you for your attention.
Thanks, John. We've got a little bit of time for some questions, if you have any. Dr. Milind is also joining us online. Maybe, Milind, if you want to ask a question or make some comments.
Yeah, thank you, Chris. Just a quick one. Firstly, for my good friend Venkin, he compared very nicely the outcomes of PD versus HD. Particularly in the first 3 years, we see a difference, and I would like to postulate, and it has been shown in some studies that most of this difference is pertaining to vascular access. If you take away the patients who have started hemodialysis using a catheter, you will see that there is not really much significant difference in the survival of PD versus hemodialysis patient. And second is for Professor Swinnen. When I started my nephrology training, which was quite some while ago, one of the first procedures I did was urgent start PD using the Seldinger technique. Is there, could you postulate or perhaps share your insights why this hasn't really taken off? Thanks.
Sorry, did anyone catch that question?
Milind, can you just repeat your question again?
Apologies. So I'll go to the second question. I first started doing procedures related to nephrology patients. So one of the first procedures I did was Seldinger catheter, Seldinger PD catheter. But this is now 15 years ago. And at the time, we all knew that this could be a replacement for putting perm cap. Could you postulate or share insights why this hasn't taken off really well to avoid catheters?
Why hasn't it taken off?
Okay. Maybe you can skip
yes, I've got it now. So why hasn't it taken off? I've got a talk coming up next, not the next one, but the one afterwards, where I'll talk about why the obvious, best, cheapest solution isn't being used. There's many reasons for it, but I think our entire dialysis system is badly, incorrectly set up. And in some ways, I I shouldn't say this, but I'll say it anyway. I mean, I'm retiring at the end of the year. We're here discussing whether we use 5mm balloons or 6mm balloons when the entire system is badly and wrongly set up, and we're using literally billions of dollars to run renal replacement therapy incorrectly. So I think there's many answers to that, but I do believe that PD, we're talking about 30% there, talking to people around the world and discussing this, our aim for PD should be 60%. Hong Kong does it in 90%.
Great, thank you. And we will follow this talk from John to invite a professor of nephrology from Hong Kong, Professor Sito. You are with us virtually, live? Hi, Professor Sito. Professor Sito is a professor in nephrology, and he has extensive work in studying PD, preventing infection, and also vascular disease and circulatory problems relating to PD. So Professor Sito will be talking about the preparing patient to switch between different modalities of dialysis. Professor Sito, I'll hand the podium to you.
Thank you. I would like to thank the organizer for inviting me to give this talk. And I was asked to talk about the preparing of patients to switch dialysis modalities, basically changing from peritoneal dialysis to long-term hemodialysis. And the major aspects to change someone from peritoneal to hemodialysis is to create a vascular access. And the problem that we encounter, obviously, are when and what kind of vascular access to be created. But obviously, there are other factors in addition to vascular access that a nephrologist must consider before changing a patient from PD to hemodialysis, which include the general condition of the patient. For patients with multiple comorbidity and very limited life expectancy, it may be very difficult to change. Hemodynamic stability is a particular problem for elderly patients. Some patients have underlying severe heart disease, so that a hemodialysis may not be feasible. And hemodialysis require the use of systemic anticoagulation, which may be risky in some patients with internal bleeding. And the patients need to be transported to the hemodialysis center twice a week at least, or 3 times a week if they're on hemo, and therefore transport arrangement may be the limiting factor in some patients. But if we focus on the problem of vascular access, now if you look at the standard recommendations by the KDOGI or the United Kingdom Renal Association, both recommend very early creation of dialysis access for HD patients. For the KDOGI, they recommend the fistula to be placed at least 6 months before on hemo, and the AV graft at least 3 to 6 weeks before hemo. And for United Kingdom Renal Association, should allow ample amount of time when the patient is has a stage 4 CKD. These are, however, recommendations meant for new end-stage kidney disease patients. For patients who are already having end-stage disease, receiving peritoneal dialysis, these recommendations many a time are not particularly targeted for and may not be entirely feasible. I say this because for peritoneal dialysis who require conversion to hemodialysis, many a time it's very difficult to tell when they would have such need. This is a retrospective review summarizing nearly 300 patients in my own center changed from PD to hemo in the past 20 years. Nearly 30% of them were due to underdialysis, but more than half of them were either due to sudden infection, peritonitis, or a sudden mechanical problem. For these patients, you actually cannot plan ahead of the time, and many of them actually were put on temporary hemodialysis, but subsequently when they could not be resumed on peritoneal dialysis, and therefore the vascular access is required for long-term treatment. For this reason, actually, in Hong Kong, the hospital authority actually put up an exercise to identify what we call high-risk PD patients, whom we believe may require conversion to hemodialysis in the near future. These patients include those who have a frequent peritonitis defined as at least 2 episodes of peritonitis in the past 1 year, or inadequate dialysis or recurrent fluid overload, inadequate ultrafiltration despite hypertonic exchange or icodextrin. But it's not difficult to define this case. The gem is to have a regular audit of the unit to plan for the modality change and arrangement of vascular access creation for these patients. I don't think in this forum I need to go through with you what are the pre-op assessment. As long as we identify patients who are potentially required to change to hemo in the near future, in addition to history and physical examination, it would be very valuable to arrange some kind of vascular mapping, probably by a duplex ultrasound to assess the suitable vein and arteries for the creation of vascular access. But the important point I would like to draw your attention to is, in fact, many elderly patients on PD have very poor vascular access. And the pendulum actually is beginning to change in the past few years. In the past, we always say fistula is first, but nowadays, fistula remains the first, but only for possible patients. There are a number of patients who have multiple comorbidity, has very limited life expectancy, and has very poor vascular access. It is now actually reasonable to consider simply using tunneled central venous catheter for providing hemodialysis without wasting the effort of creating AV fistula or AV graft for these patients, but to change and to divert the effort of our vascular surgeon to more promising cases. This is what we call a patient-centered approach in deciding the choice of vascular access. I don't think I need to emphasize an additional important thing. Once we identify what kind of vascular access, if we decide fistula or graft is useful, then it is important to identify good surgeons. I won't dwell on it, but this very interesting study actually showed that younger surgeons are more energetic and actually many a time have a better outcome as long as they are adequately trained. But what do nephrology contribute? First, in addition to identifying potential cases that require the change, we should put very much effort to preserve the veins for future possible vascular access creation. And we have to arrange training for the phlebotomists. And in addition, we should avoid the use of intravenous administration of any agents, including minimizing the blood transfusion by more liberal use of erythropoietin, minimizing the use of intravenous antibiotics, and to treat underlying infection if once it develops. And we should maintain a very good communication with our vascular surgeon and radiologist for preoperative assessment and also postoperative care of these patients. So, Mr. Chairman, ladies and gentlemen, I would just like to give my 2 cents on this topic. And for nephrologists, the important point that we could contribute is to identify high-risk PD patients whom we expect to be able to be requiring the change from PD to hemodialysis in the near future. And for all of our patients, we should work very hard to preserve the veins and to be realistic when we are deciding what kind of patients are requiring what type of a vascular access for creation. Thank you very much.
Any questions? Shannon? Yes.
Thank you, Professor Situ. That was an excellent talk. Excuse me if I heard your talk incorrectly, but I thought you said that over 20 years of practice, you had only converted 289 patients from PD to HD, which to me seems very low. So are a lot of patients dying on PD, or are a lot of patients getting a transplant? Can you explain why the conversion number is so low?
There is a limiting factor because you know the situation of Hong Kong is that we have a PD first, and the availability of hemodialysis facility actually is quite limited. So many a times, at least in the early 2000 to 2010. Actually, many a time patients with very under dialysis or repeated peritonitis, we still dwelled on. Honestly, that's not ideal practice, but that was a realistic arrangement. That's why the number of conversion from PD to hemo actually is no more than 10%, probably only 5% of a dialysis population every year or so. So that's why the number was very small. But partly because of that, you can see many of them we could not plan, and it's because of mechanical problem and peritonitis. More recently, we have a more available hemodialysis facility, so we began to plan and foresee which patients we'll need, and therefore we change it beforehand. If you break them down into the number of cases converted to hemo, actually there was certainly an increase in the past 2 or 3 years.
Yes, NC.
Dr. Sito, in this part of Asia, we all admire Hong Kong that you got a very high rate of PD. In fact, we are trying to see how we can convert our hemodialysis to PD. So can you tell us what's the secret? I mean, how do you convince your population to go on PD? I think that's a really good strategy.
Now, there are two sides of the story. On one hand, it's a government policy, so it's not too difficult for us to explain to the patient, you must have PD if there's no medical contraindication. But on the other hand, the local nephrology circle in Hong Kong do put up very much effort to convince our patients that peritoneal dialysis is at least as good as hemodialysis. One very good strategy that we use is we every now and then we put up patient models or model patients, a very successful one. Some are very healthy patients put on peritoneal dialysis leading very productive life. But more importantly, every few years we have honestly a fairly senior government official running into end-stage renal failure and put on PD, and then everyone will see, oh, even very senior government servants, senior people will have peritoneal dialysis, and they're doing well. They're still doing their speech in the Legislative Council without any problem. So that's a really good advertisement, I would say.
Thank you very much, Professor Sito. So in the interest of time, we'll be going to the fourth talk of this section. I would like to invite Dr. John Swinton to come up to the podium again, and he will be talking about patient-centered, multidisciplinary integrated renal replacement therapy unit for end-stage kidney disease patients. I think this is a very, very important topic.
Thanks, Jackie. So as I sort of progressed through renal replacement over the years, I came to realize that we weren't going to solve the problems of renal replacement therapy by putting in bigger balloons or cutting balloons, that we had to go further back to solve the problems. And this talk sort of summarizes it. So who am I to talk about this? Well, I've had about 20 years in hemodialysis and more recently 5 years in PD. I've been forming lots of fistures. I've been doing hundreds of endovascular procedures, lots of sonography, and worked as an educator and a researcher. So I've done 31 fistula workshops in Australia and New Zealand, and I've done 27 fistula workshops throughout the world in the United States, Philippines, Singapore, Hong Kong, Malaysia, Thailand, etc. So I've seen a lot of how dialysis works and how dialysis doesn't work in both the developed and developing world. This was KLVAC 2010. That's Ho Chi Minh City 2015. That's Karachi, Pakistan, SIUT, which is Sindh Institute of Urology and Transplantation. I've been there 5 times. This was DASY in 2017, Chiang Mai 2015, SIUT again in 2015, Hong Kong in 2011. That was part of that initiative to increase HD. They asked me to come across and they sent their registrars to a hospital. Sydney in 2005, Sydney in 2012, DASY in 2019, Chiang Mai 2019, Karachi again 2016, San Diego, CEDA in 2018, Kuala Lumpur 2017, Karachi 2019, Bali, Indonesia 2019. Then the COVID years, which were a pain. So that was a Baxter webinar, and that was DASY COVID. So renal replacement therapy is a single entity. It's the management of people in end-stage renal failure. Renal replacement therapy starts when the attending renal physician says, I think your kidneys are going to fail before your life's up. That's when it starts. And that's when the nephrologists have to start taking action, like protecting their veins. They know these people are going to go into renal failure, their veins need protection. And the management ends when the patient dies. Now, if it's a 65-year-old diabetic with heart disease, that's 3 years later. If it's a 15-year-old with IgA nephropathy, that might be 50 years later. So it's a huge undertaking, this. And what are we trying to do? We're trying to restore the patient as far as possible to a normal life expectancy, quality of life, function in life, with zero complications. Okay? Ridiculous me saying zero complications. What is the target for the Swedish government for their road toll in 2030? How many people are going to die on the roads in Sweden in 2030? Zero. That is their target. No accidents that are fatal in Sweden. So you've got to aim high. Renal replacement therapy has 4 arms, as you know, and the best outcomes are achieved for the patient and the system if all 4 modalities are available, so you need all 4, and they have to be efficiently delivered and efficiently integrated. And that's where we break down. Even in countries like Australia and America and Europe that have got all 4, we're still not doing it properly. This is the integrated dialysis team. I've been putting up this slide for many years. Dialysis nurse and dialysis coordinator are the principal people. The problem with current renal replacement therapy is that it's fractured over time, it's scattered across multiple disciplines, many different approaches, many different settings and venues, and it produces somewhere between many avoidable problems to an unholy mess. And it's punishingly expensive. This is the slide many of you will have seen at some of my meetings. This is ANZ data projecting costs in Australia. So in-centre dialysis in Australia now is 100,000 Australian dollars per patient per year. The Aussie dollar is about the same as the greenback. Per contra, home hemodialysis is half that price, 50,000. And home PD, also half that price. And even more interestingly, the best treatment, transplant, is much, much cheaper. So the cheapest treatment of renal failure is also the best. So we've got to get it right. This is something that was sent to me. John Oliver, I don't know if anyone watched him. He's a British comedian, but he does serious interviews. And he was looking at dialysis in the United States, which is amazingly corrupt. And this is what he said. 2% of the American federal budget is spent on education. 2% of the American federal budget goes on educating Americans. 1% of the American federal budget is spent on hemodialysis. The American federal budget is $4.2 trillion a year. Treatment of one disease with one modality in the United States is absorbing hundreds of billions of dollars, according to this. That's what he said. I think it's well researched. So the evolution of healthcare, there's rapid change all over the world in medical science, technology, patient demographics, disease patterns, etc. And I think the traditional healthcare models are not keeping up in many fields, but particularly in dialysis. I think the division of healthcare into surgery, medicine, and imaging is obsolete. I think it worked very well in 1910. It does not work in 2022. We've got to get rid of the College of Surgeons and the College of Physicians. Distinction between an interventional physician and minimally invasive surgeon is an academic point. And the care of complex comorbid patients have become ever more specialized and fragmented. I don't want to run over time, but my house surgeon said to me, this is a few weeks ago, she was going to discharge my fistuloplasty patient, and his blood pressure was a bit high. So she was just going to check his medications and maybe give him a GTM patch. The nurse said to her, no, you've got to call the cardiology team to come and review the patient. Healthcare should be disease-based and patient-based. So, what determines the choice of renal replacement therapy? There's 2 different things, the short-term and the long-term. So you've got to do the right thing for them today, but also the right thing for them tomorrow. So this is the short-term problem. So this is a patient admitted, 55-year-old diabetic, no peripheral pulses, end-stage renal failure. He gets a VAS cath and a brachiocephalic fistula. He's got an ischemic hand. So they say to me, Dr. Swinnon, should we do a drill procedure? How do you treat Steele syndrome? The answer, this is not a fistula problem. He should never have had a fistula. He should have been given a PD. But we don't have a PD program. So that's the wrong decision made on presentation. This is the result. Failure of dialysis management, forearm amputation, unhealed amputation wound. This patient asked me to take his photo, and he said, don't blank out my face when you show this at your meetings. I am not happy with what happened. This is, yeah, okay. Do you want me to go into this or skip it? Skip, okay. Correct treatment over time. So you've got to plan the long-term management as well. So this is a 30-year-old male, a bricklayer with 3 children, comes in with renal failure, gets a VASCAT, a fistula, and a transplant from an uncle within 6 months. Great result. Good functioning kid, fistula, back home, everything's good, except he's got superior vena cava syndrome from all the VASCATs. His face is swollen, his arm's swollen, he can't work anymore. He's unemployed, he can't feed his family. Is that a success? Do we need to destroy patients' central veins when they go into renal failure? Is that a necessary part of their treatment? So, correct treatment at the correct time. I'll just skip to my conclusions. So, you should never complain about problems if you don't have a solution. So, national health policy is very important, and it needs advocacy from everyone here. Thailand has a PD First program which is working well. Australia has remodeled its organ donation, and we've doubled the number of kidneys we're placing in about 2 to 3 years. So doubled our transplant rate. Spain and Belgium have an opt-in rather than opt-out system. The US federal reimbursement is terribly biased towards HD. Secondly, interventional nephrologist is part of the solution. It puts the patient care and their access under the same specialist. So I've always supported interventional nephrology. Multidisciplinary renal replacement therapy care centers are necessary, and they should be modeled on cancer care centers. So the transplant HD and PD should be integrated in time and place without cost of referral. And I think the minimally invasive revolution is going to make a big difference. With selding a PD and endovascular AVF creation and endovascular fistula treatment, the single specialist can offer the patient everything without referral. So we've made a huge progress in renal replacement therapy in the last 50 years. Many have been driven by technology, but our systems have lagged and not kept pace. Better integrated renal replacement therapy is the task of the next generation. So thank you all for your attention today, and thank you for all your support and friendship over the years.
Thank you very much, John, and this is truly inspiring. However, I think we really couldn't discuss this at this moment. I think we will need like 1 hour for the discussion, which we can carry on during our gala dinner. So please stay on this evening for gala dinner and have a long chat with John. Okay, so I think we will have to conclude this section and really thank all the speakers for the great talk, and it's informative as well as inspirational. Thank you very much.